Hello, Dental XP viewers. My name is Ehab Musa. I am a periodontist practicing in New Orleans, Louisiana. The topic I'd like to share with you all today is partial extraction therapy and immediate loading in clinical practice, synergy for success. So I come originally from Alexandria, Egypt, which you see in the top photo here. This is where I went to dental school. Following that, I moved to Cleveland, Ohio. This is where I did my periodontics residency. And following finishing the periodontics residency, I then moved to New Orleans, Louisiana. This is where I currently practice. I'm in private practice, pretty much limited to periodontics and implant dentistry, and some implant restorative dentistry as well. So a few months back, I really had the absolute pleasure of participating in the Dental XP Regenerative Summit. It really was a terrific time for me. Really, one of the greatest moments of my career was being able to stand on the same stage with my mentors and the people I look up to. I had the chance to discuss one of really my favorite topics, which is bone augmentation and implant dentistry. And although it was a great summit and a lot of great ideas, a lot of great techniques were shared by everybody, I can't help but think of one particular question that I'd like to start off my presentation with, and that is, what are we looking for in clinical practice? As practitioners, going every day into our clinical practice and treating our patients, what is it really that we're looking to establish? What is it that we want to have every day in our clinical practice? And when I think of that, I really think of four main things. Number one, obviously, we all want to be successful in the techniques and the procedures we perform. We want to be able to be predictable, reproduce our results, reproduce our success. Obviously, we want to be efficient, minimize the number of appointments that we treat our patients in, decrease the time of the appointments, and that really helps us be efficient on running our practice and allows our patients to have a more positive experience. The less surgery, the less the number of appointments, the shorter the appointments, the happier our patients are going to be in the end. And so here's a case where a patient presented to my practice and she has a failing left central incisor. And we can immediately see here the fistula that leads to the apex of this tooth. We go ahead and flap the area and we immediately see the large fenestration defect that we have to manage here in this case. And so my decision moving forward in this case was to place an immediate implant combined with a bone augmentation procedure. So we use the Versa drills, we drill our osteotomy, place the implant in an adequate restorative position. Following that, we perform a GBR procedure on the labial aspect, bone grafting, collagen membrane, connective tissue graft on top of that. And then actually later on, when it came time to uncover this implant, I did perform a second connective tissue graft. And this is the result that we were able to achieve in this case. And this is how this patient goes back to see her restorative dentist. And so I'd like to stop for a second and reevaluate the success of this case and reevaluate how I performed in this case. And so if I look at whether this case was successful or not, well, we do have some scarring in the final result, but I think that we've managed to achieve a decent result. So I'll go ahead and say that this case was successful. Is this predictable? Is this type of augmentation reproducible in different cases? And for this, as a fenestration defect, this is somewhat predictably, can be predictably treated. Sure, we have other augmentation cases that are not so predictable, but I'll go ahead and say that this is a predictable technique and a predictable result to be achieved. But was this sufficient? This patient went to, although I did a simultaneous implant placement with GBR, but I had to go back, perform a second connective tissue graft procedure, and I saw this patient multiple times, And so I don't think that this is really an efficient treatment. And I'm also positive that this patient didn't have such a positive experience. I had to harvest two connective tissue grafts from the palate, and we performed the GBR procedure. And we all know that these procedures are, and most of the times, will be painful to our patients. And so, again, I don't think that I was able to provide this patient with a positive experience. And so, in those cases where our patients present with deficiencies, whether bone deficiencies or soft tissue deficiencies, augmentation is really inevitable and we really don't have any other choice. But what about cases like these? Cases where the patient present to us with, yes, an unrestorable tooth, but they also present with an intact periodontium. And through our implant placement techniques, we actually lose volume, whether we're losing vertical tissue volume, as you see on the left hand of the screen, or we're losing horizontal tissue volume on the right hand of the screen. And these are all my cases. And you can really see that although these cases on the bottom have not been restored yet, we're already starting off on the negative side, and we're already starting off with a tissue deficiency. So how bad are these cases going to look 5 years down the road, or even 10 years down the road? Or are these implants going to be there even 10 years down the road? And we know the story behind all this. We know from the study by Araujo and Lindy that you take a tooth out, you lose the bundle bone and the periodontal ligament, and that triggers a chain of reactions where you start losing horizontal and vertical height of particularly the buccal bone. And so I'd like to propose a question here. Can we do better? Can we do better in the cases that present to us with an intact periodontium, where the tooth is still there? And we all are familiar with this study. This is really a landmark study by Dr. Hertzler and Zur, where they investigated leaving a part of the tooth within the socket and placing the implant in a palatal position, and hence the socket shield technique. And what they found was that they were able to pretty much maintain the volume of buccal tissues vertically and horizontally by maintaining that labial sliver of tooth segment. And from that study, we really arrived at the multiple partial extraction therapy techniques that we employ in daily clinical practice right now. And so, really, in a nutshell, partial extraction therapies are techniques that aim to maintain either a part or the entire root of the tooth. And by doing that, we're able to preserve the bundle bone, the periodontal ligament, and so we're able to place our implants, but at the same time eliminating or preventing any bone and tissue resorption that traditionally follows. And so our outline for today is really quite simple. We're going to review some of the partial extraction therapy literature that's available to us. Following that, we're going to go into the actual technique and the concept behind it. We're going to talk a little bit about immediate loading, and then we're going to review some clinical cases that demonstrate the combination of partial extraction therapy techniques and immediate loading in daily clinical practice. And then we'll finish with some conclusions. And so a very important question that rose when partial extraction techniques were first developed was that what happens between the shield and the implant surface? The first study by Hertzler and Zur, they placed Emdogain between the shield and the implant surface, and they found histologically they got new cementum in that gap. Then the same group later on in 2015 repeated the study. However, this time they changed the configuration of the socket shield somehow, and they did not place Emdogain between the implant surface and the shield. And this time actually they found that they got bone between the implant surface and the shield. And this again was another animal study. Now we go into human case reports, and this comes from the Mitzias group in Greece. And what we can see here is that they found that between the implant surface and the shield in the coronal third, they actually had connective tissue, non-infiltrated connective tissue between the implant surface and the shield. We go to the apical two-thirds between the implant and the socket shield, and they actually got bone formation between the implant and the shield. At the apical aspect, they did get some cementum from the apex of the tooth. But one thing that we have to point out in this case report here is that the shield configuration is different from what is traditionally done nowadays. Typically now, we will trim the shield to the level of the alveolar bone, and then we'll place the implant about 1 millimeter to 2 millimeters apical to that crest of alveolar bone. And I'm sure that this will have some impact on the type of tissues that we will get within that gap. Here's another case report from the Dental XP group here on the website, and this is from Chuck Schwimmer, Howie Gluckman, Maurice Salama, Jonathan, and Gregory Pett. And here what we see actually is that this implant was placed unintentionally in contact with a retained root fragment. And this implant was extracted, and the histological analysis shows that there is actually alveolar bone between the implant surface and the surface of the root. And so these are only parts of the literature that's out there regarding partial extraction therapy techniques. There's really a whole lot of other studies out there right now. And the partial extraction therapies technique are not only limited to the socket shield, we actually have the Pontic shield now, which we can use to preserve Pontic sites. And we also have root submergence techniques that have been presented in literature years and years ago, and these also aim to preserve Pontic sites for us. And so really the take-home message from all these techniques is that we use those techniques for true preservation. It's not like we're preserving a socket site by simply grafting the socket and still will lose some ridge width and some ridge height. This is actually true preservation. We're preserving the entire width and the entire height of this alveolar ridge because the body simply does not recognize that the tooth has been extracted. And so we go into the actual technique, and again, we're talking about three main techniques here: root submergence technique, Pontic shield, and socket shield. Pontic shield and socket shield are essentially the same technique. However, in the socket shield, we are placing the implant palatal to the shield. In this Pontic shield technique, we're not placing the implant. So we look at the root submergence technique, and the way we go about this technique is that we first use a carbide burr to cut the crown off the root surface as close to the level of the bone as we possibly can. Then we'll use a round diamond burr to simply trim the surface of that root and bring it slightly subcrestal. That surface of the root from the coronal aspect should really be concave below the bone surface and as subcrestal as we possibly can. Now we go into the socket shield and Pontic shield techniques, which are essentially prepared in the same fashion. And this becomes more technique sensitive compared to the root submergence technique. And here's a case to demonstrate the steps of performing a socket shield. So here's a tooth that is essentially non-restorable. And the first step in this technique is to perform the mesiodistal cut. And I believe that this is really the key in this technique, and this is what can simplify it or make it a much more complicated technique. And we're using a tapered carbide burr, a long shank carbide burr here, and essentially with that mesiodistal cut, we're aiming at including the apex of the tooth within the palatal or lingual segment that's going to be extracted. And so we're essentially following the root canal space and trying to angle the tip of our carbide burr slightly buccal to include the apex of that tooth. Once we see a line of blood, a line of bleeding between the two segments, that is an indication that we've essentially penetrated the root surface. Following that, we'll go ahead and engage the lingual segment from the palatal aspect. Typically, I'll use a periotome to go within that periodontal ligament and try to simply push that palatal segment to the buccal. dislodge it from the palatal bone to the buccal. I'm never going in between the buccal and the palatal segments and exerting any pressure to the buccal. Shield immobility of that segment is really absolutely necessary. And so once we're able to extract that palatal segment, then we'll use a combination of diamond and carbide burrs to shape that labial socket shield segment. Following that, we'll go ahead and use an end cutting burr, an end cutting carbide burr, and this is what essentially going to provide us with that prosthetic space. This is something that I learned from Howie Gluckman, and this is something that is absolutely essential in preventing internal exposures later on with socket shields. In this case, we go ahead and graft the labial gap with freeze-dried bone allograft, and primary stability was not high enough in this case, and so we're using a customized healing abutment. And this is how the extracted segment should really look. We should extract the lingual segment of the tooth along with the tip or the apex of that root, because we really don't want to leave behind any apices and take any chances for infection in the future. This is how the case looks after 3 months, and we can see the preservation of both tissue horizontal width and vertical tissue height as well. And this is how the case looks when it's restored in the end. And again, we can appreciate the natural horizontal and vertical tissue contours that we're able to preserve. And so you may be looking at all this and you're thinking to yourself, why am I going to complicate things? Why am I going to complicate a straightforward extraction by performing all these crazy techniques that he's talking about? Well, let's look at some of the benefits of partial extraction therapy. Well, obviously, the first one is aesthetics. You can look at those photos on the top and the bottom of the screen. Forget the prosthetics for a minute, but we can appreciate the natural tissue contours. On the top photo, we have preservation of vertical tissue height that is really symmetrical with the neighboring natural teeth. We go to the bottom photo and we can see again no horizontal deficiency, no dip within the soft tissue that can differentiate an implant from a tooth. Long-term stability is obviously another main key that is often overlooked with partial extraction therapies. This is a case that this is actually my first socket shield case that I performed in residency. And in the lateral incisor, in number 7 here on the screen, I performed a traditional or conventional immediate implant placement. And in the left central incisor, I'm performing a socket shield technique. This patient went away and I did not see her until a year after the surgery, but look what the situation looks like when she comes back. You can see the absolute maintenance of horizontal ridge width on the left central incisor. But look at how much horizontal tissue loss we've lost on the lateral incisor. And this has only been 1 year. Again, how is this going to look like in 5 years? How much more prone is this implant going to be to peri-implantitis when it's lost all that tissue? A third and really very important benefit of using partial extraction techniques is overcoming anatomical restrictions. You can see in the top photo here how those implants are really closer to each other than we have been traditionally taught. I don't have 3 millimeters in between those implants simply due to the anatomy of the roots and anatomy of the space that I have. However, partial extraction therapy allows me to maintain the inter-implant bone in between and also the vertical papilla height in between those implants. We go to the bottom photo and we see that if I had performed an immediate implant placement in lower incisor without having a labial gap like I'm showing in the photo here, well, I would probably come back at second stage and I would find the labial implant surface completely exposed. I would probably lose a lot of that labial plate of bone because we know that resorption proceeds from the outside towards the inside of the alveolar envelope. However, maintaining that shield allows me to maintain the entire ridge width and allows me to get close to the labial plate of bone with my implant surface again, and this is due to anatomical restrictions here. One more very important factor that we have to consider is treatment complexity. This patient was treated with immediate implant placement. We performed partial extraction therapy in the form of Pontic shields and socket shields. This was all that was done. We did not perform any free gingival grafts. We did not perform any connective tissue grafts on this patient. And yet we see that when it came time to the final restorative of this case, we had adequate width and thickness of keratinized gingiva around those implants to allow us to maintain this case long term and allow us to preserve the health of those implants long term. And again, like I said, this was all that was done in this case. And so for this patient, I'm sure they had a positive experience. I did not have to go to the palate to harvest large free gingival grafts, or I didn't have to perform large bone grafts and large flap advancements in this case. And so again, this adds to the positive patient experience when we're reducing the treatment complexity. And so I'll shift gears a little bit here and I'll turn into immediate loading. And we all are familiar with what immediate loading is, and it's loading the implants basically within a 1 week period within the placement of the implants. And again, I'm not a prosthodontist, and this is not really the main topic of my presentation. The main topic of my presentation is the combination of partial extraction therapy with immediate loading and how much of a great service this can be to our patients, and also how much of an asset this can be for our practice and how much it can impact the success of our practices. And so we're using partial extraction therapy to preserve the tissue volume, but we can also immediately load our cases or immediately provisionalize our cases to preserve the architecture of the tissues. One big benefit of applying immediate loading in our cases is increased case acceptance. Telling our patients that they'll be able to walk out of the office after the surgery with whether it's a single tooth or a full arch case really does impact the case acceptance. Efficiency obviously is another important factor. We don't have to worry about bonded provisionals that will keep falling off and seeing the patients for multiple appointments to rebond this Pontic tooth. Actually, immediately loading the case and immediate provisionals will improve the efficiency of our case. Especially in large cases, test driving the case is really very important. When we immediately provisionalize a case, the patient has a period of about 3 months where they can test the aesthetics, the phonetics, the occlusion. They can tell us what they like, what they don't like, and then we exactly know what we need to change when it comes time to the final restorative of the case. Finances is a very important factor. A lot of those large full arch cases can be very expensive, and we know this is expensive stuff that we're performing. However, when we tell our patients that when they get an immediately loaded prosthesis or an immediate provisional, well, then they can stay with this provisional for an extended period of time, whether it's 6 months, whether it's up to a year, and they can use this time to figure out the rest of their finances. And I feel that patients really do appreciate this option when we present it to them. And last but not least, we're not talking about something that is new or a new technique that we're trying. Immediate loading is something that is very well documented in the literature and has been around since the 60s. And so we're all familiar with this graph that shows the difference between primary implant stability and secondary implant stability. Basically, the insertion torque is really what provides us with that primary implant stability, and this starts to go down between 2 to 4 weeks, and at the 4-week mark is when we start seeing an increase in the secondary implant stability. And really the whole take-home message from this graph is the importance of having primary implant stability and having high insertion torque or adequate insertion torque to be able to proceed with immediately loading our cases. And a concept like osteodensification can really help us out in this particular aspect, but this is not my topic, and maybe perhaps a topic for another presentation. So again, we look at the evidence that we have for immediate loading, and there's really a multitude of studies available in the literature. And I will cite one particular study, and this is from Dr. Leonard Linkow, and this shows immediate loading, or the application of the immediate loading concept, since the 1960s. And so again, we're not discussing something new. This is something that's been around for a while. And so moving into another study, and this is a systematic review from Dr. Tiziano Testori, and I'm just going to quickly go through this study, but this basically tells us that we have a lot of evidence for immediate loading of cases, whether we're talking about fixed cases or actually talking about removable cases. And there's actually evidence for immediately loading overdenture cases when placed in the mandible. We look at fully edentulous cases. Typically, 4 to 5 implants are what's used for the mandible. Going into the maxilla, we're typically using 7 to 8 implants. And I have to say that this is pretty much what I'm shooting for in my clinical practice. I'm almost very rarely planning a case from the beginning with 4 implants only. And this is not because 4 implants are not going to support the prosthesis. This is simply over engineering the case, just so if I have a failure in one of my implants, it does not stop me from proceeding and moving forward with the case. We look at single unit cases, and survival rate is similar for maxilla compared to mandible. Again, when we compare immediately loading single units compared to delayed loading, the success rate or the survival rate is not all that different. Now, when we move into multiple units, whether we're talking about 2 or 3 or 4 units, this is really the most or the least documented in the literature. However, there is evidence that the rough surface implants do tend to impact the success of these cases. Now, again, for the purpose of today's presentation, I would like to spend what's remaining of time here to focus on full arch cases and single unit cases. We're going to go through some clinical cases that really outline the incorporation of partial extraction therapy along with immediate loading in those two particular scenarios. So when looking at single unit cases, I do feel that a flapless approach is what's typically recommended when performing our socket shield procedure and immediate loading of the case. An insertion torque of 35 newtons is what is typically recommended as the minimum to proceed with an immediate load of the case. CBCT is really vital when planning those cases ahead of time, and this is a very nice classification by Dr. Howard Gluckman. And really the biggest benefit of this classification is that we can look at the type or the classification that we're dealing with, and then this classification tells us which classes we're able to obtain immediate implant placement in, which cases are not indicated for immediate implant placement, and which of those classifications we're going to be able to obtain screw retained access, which is typically what we're going for, and which classifications we're going to have to resort to we're going to have to resort to a customized abutment and a cement retained restoration. Obviously, patient selection is another very important factor. We need to select a patient that's going to be compliant, a patient that's not going to go out and start using this tooth to bite into sandwiches or not follow our instructions. Occlusion is also a very important aspect. We need to make sure that we have enough posterior bite support, we have enough clearance to place our provisional out of contact in both centric and eccentric occlusion. As far as the provisional itself, these are the 3 main techniques that we incorporate in our practice. My personal favorite is using the patient's own tooth or the patient's crown that he presents with to use as a provisional. I feel that patients prefer that the most because they pretty much walk out of the office the way that they walked in. We can use a lab fabricated shell that the lab can prefabricate ahead of time. And my least favorite technique really is the direct technique, and this is mainly because in my hands, the aesthetics with this technique is inferior to the first 2 techniques I've mentioned. So let's look at the first case, and this is a patient that presents to us with a failing left central incisor. We go ahead and we remove the crown off the tooth, and we have a post that is loose within the tooth, and so we're able to pull that crown right off. And for this case, we're going to go ahead and perform a socket shield technique, and we're going to use the patient's own crown to provisualize the case. And so as a first step, we're going to use the carbide Fisher burr to perform our mesiodistal cut, incorporating the apex of the tooth into that palatal segment. We're going to extract the palatal segment, and then I'm going to place an implant in a palatal position to obtain a palatal screw-retained access. We're going to graft the gap between the implant and the socket shield utilizing a bone allograft in this case. Again, this is how we modify this patient's crown. And in order to perform this type of technique, when we're modifying the patient's crown, it's very important that we use irrigation when we're drilling through the crown so that we don't get cracking of the porcelain. We'll then go through the traditional steps of bonding. We're going to use a ceramic etch followed by silane, followed by a bonding agent. And then we're going to use the shell that we've created to pick up the temporary abutment within the mouth. And this is how the patient leaves the office that day. I didn't quite reline the tooth in the same position that the patient walked in with. However, this patient was very happy with this as a provisional, and this is PRF that you see sticking out of the sulcus here. And this is the type of result that we're able to obtain with this case. Again, once we start using these techniques, we really get used to these types of results. We get used to the preservation, the absolute preservation of both tissue height and width. Now moving on into a more complex case presentation, and here's a patient that presents with a fracture of the upper left first premolar. We also see that this tooth presents with a periapical lesion and a fenestration through the labial plate of bone. And so moving forward with this case, the plan is to perform a socket shield combined with an apicoectomy procedure. And this is a technique that I've seen or I've learned from people like Jorge Campos, Howie Gluckman, Sinjana Pohl, and I do feel that this is a very predictable technique. And for provisionalization here, what we're going to do is we're going to use the labial segment of this patient's crown as a veneer and simply veneer it onto the temporary abutment using composite resin. And so this is how we perform the case. We're utilizing an aesthetic buccal flap here. I probably should have placed my horizontal incision more apically into the mucosa, reducing the chance of scarring. And this is something that I've learned and modified in my technique. However, this is the incision. We perform the apicoectomy, making sure to clean the tip of the root and to clean any soft remnants around that tip of the root. We're performing the socket shield technique, and we're trying to preserve as much length as possible of the shield, because the shorter the shield apicocoronally, the more likely we are going to have shield movement or shield mobility, and that is really the biggest problem that we can face, or biggest complication that we can face in socket shield. We go ahead and place our implant, we go ahead and drill for our implant. We're using osseodensification here to try and increase our primary stability. Here you can see the periapical x-ray with the osseodensification drill. We place our implant and we're able to obtain adequate primary stability and to proceed with immediately loading the case. Here you can see the implant placed in an adequate restorative position to obtain, again, screw-retained access for our case here. This is how the patient leaves the office. Again, we used the labial segment of the patient's tooth. We luted it to the temporary abutment, and we simply used composite resin to build out the palatal segment. And this is how we see the patient at 2 weeks post-op. Now, never mind the scar that you see here, and this is really my mistake in performing the incision in the keratinized gingiva. But we can see the natural and harmonious tissue architecture that we've preserved basically by using this technique. And this is how we see the case at 3 months post-op at the time of impression. And again, both vertical and horizontal tissue preservation. This is not really anything that I'm doing. This is not really anything specific to the technique I'm performing. This is simply the beauty of partial extraction therapy. Now again, shifting gears and talking a little bit about full arch cases. And when we're talking about full arch cases, we really have two models that we're talking about. And I'm using Dr. Carl Misch's classification here. If we're talking about an FP1 or 2 type of prosthesis, basically a prosthesis that does not include any pink into it, well, this is more indicated in cases where we have no or mild periodontal attachment loss on the teeth that we're working with. In those types of cases, implant position becomes very critical. We have to place our implant within the confines of the tooth. The implant cannot emerge in the interproximal aspect between the teeth and the final prosthesis. And so because implant position is so critical, my method of choice is to utilize guided surgery. To place our implants, I find it difficult to place those implants freehand predictably, and to immediately load or provisionalize the case, a milled PMMA that we can reline within the mouth is a very suitable option. Now we shift into an FP3 type of prosthesis, a prosthesis that incorporates pink within the design, as you can see on the screen here. And this is more indicated for those cases with moderate to severe attachment loss of the teeth if they're present, or if a case presents with an alveolar ridge defect and bone reduction and alveoloplasty become necessary in order to place our implants. In those types of cases, however, implant position can be more forgiving. Again, we see because we're dealing with a larger prosthetic design, we have more surface area onto which our implant surface or implant platform can emerge. With those types of cases, I feel freehand can work very well with an accurate study of the CBCT, or actually guided surgery obviously can work as well and cut down obviously on the treatment time. As far as provisionalization, a chair-side traditional denture conversion works well. However, a prefab fabricated PMMA provisional that we can reline within the mouth, whether it's milled or printed ahead of time, obviously can cut down on the treatment time and increase the efficiency in our cases. So let's look at our first case here, and this is an FP1 type of case that we're dealing with. And this patient presents with an edentulous lower jaw that is very deficient in bone width, and this was treated with a traditional GBR approach utilizing titanium mesh. However, we're focusing on the maxillary arch here. We have teeth that present with root surface decay. We have hopeless teeth within the posterior areas of the jaw, malpositioning of teeth, and so the treatment plan moving forward with this case is implant extraction or partial extraction, if I may say, and implant placement with an immediately loaded FP1 prosthesis on the maxillary arch. And so again, for these types of cases, guided surgery I feel is almost necessary in order to be predictable, at least in my hands. And so I was working with my friend Rami Gamil on this case. And this is really the beauty of the digital workflow. This is a case that I had performed in Egypt at my father's clinic. However, we were planning this case while I was in the States. Rami was in Egypt. We went back and forth until we developed a plan. I arrived in Egypt just one day before the time of this surgery, and everything was ready. We had the guide ready, and everything just went very smoothly. And so again, we're planning the case, and based on the wax up that Rami made, the digital wax up, I then went ahead and used this to pre-mill a PMMA temp. And this was done here in the States before going back to Egypt. And Edwin Key, my good friend, helped me with milling this PMMA temp ahead of time. And so again, we take a closer look at the maxillary arch, hopeless teeth, decay on the root surface, and the crowns of those teeth. And so what we do here is that we're going to use a tooth-supported guide on the teeth or on the anterior teeth, and we know that this is the most accurate type of guide because it's supported by the teeth. And so we're going to use the guide to place the posterior implants, and then we're going to remove the guide and place the anterior immediate implants freehand, simply because we have the roots and we have the teeth to guide us into placing those implants in the adequate position. So again, utilizing guided surgery, utilizing osseodensification for internal sinus augmentation in the posterior areas of the arch, In the anterior area, we're utilizing a combination of socket shields and root submergence techniques to preserve the horizontal ridge width here. We see that we have a horizontal atrophy in the left lateral incisor position, and so we're going to develop this pontic site with a connective tissue graft from the tuberosity, and this is a technique that works very well. And in those cases, we're already performing a lot this day. When we perform so many partial extraction techniques in that case, this obviously adds to the treatment time. And so I always feel that it's easier on the practitioner and on the patient to simply place healing abutments that day. The patient goes home, patient can then come back the second day or even the day after that to perform the immediate load of the prosthesis, and things just go so much smoother when we do them this way. This is how we see the patient back at 48 hours post-op, and we can immediately see in the left central incisor position that we were able to bulk up this area utilizing the connective tissue graft. We then reline the PMMA prosthesis in position. We're going to the fixture level in this case, and we're using non-engaging temporary abutments to immediately load this case. This is how the patient presents back at about 5 months post-op. Unfortunately, this case is not yet restored due to finances. However, we can see that we were able to preserve the architecture of this case. We were able to preserve the horizontal dimensions of this case simply by applying partial extraction therapies technique. And this is another view of the same case to see the vertical and horizontal tissue preservation that partial extraction therapy can yield to us. Now going into the final case that I would like to present today, and this is a patient that presents to us with multiple missing teeth, both on the maxilla and the mandible, but she has a partial on the maxilla right now. She would like to focus on the mandibular arch, and we're going to continue with the maxillary arch at a later date. And so she has very heavily restored teeth on the lower arch, lots of recurrent decay underneath those fillings and the crown surfaces. She also has severe horizontal atrophy in the posterior mandible, both horizontal and vertical atrophy, which makes it very difficult to place any implants in the posterior areas of the jaw. And so moving forward with this case, the plan is to extract the lower teeth, or actually partially extract the lower teeth. We're going to utilize a concept of combining angled implants and straight implants in the anterior region of the jaw, and then immediately loading the prosthesis with a traditional chair side conversion here. So this is how we start the case, and we're not doing a whole lot of bone reduction. We're simply reducing 1 to 2 millimeters of ridge height just to get a flat and stable crest onto which we can place our implants. We can see on the photo towards the right side here that we have root canal treated teeth, and it's very important to remove the gutta percha if we're performing socket shields or pontic shields. Personally, it has become my preference in full arch cases to not leave behind full roots. My preference is to perform a combination of socket shield and pontic shields. There is really no evidence to support my preference. It is simply that I feel that leaving behind an apex can be or can have a higher chance of problems compared to leaving behind a shield or a labial segment of the shield. We go ahead and place our implants, angled implants in the posterior area of the mandible, 3 straight implants placed in the anterior region of the jaw. We're using a combination of socket shields and pontic shields in this case. No extractions, no full extractions were done in this case. We're retaining very thin segments of the shield. Obviously, we would like to retain a thicker segment of the shield. However, this becomes more of a challenge in the lower anterior area because of the anatomy of the alveolar ridge. We're going to utilize multi-unit abutments to correct the angulations of these implants. We're always trying to emerge with those cases more palatal to or more lingual to the teeth, because this, if we emerge within the teeth, this tends to weaken the acrylic and weaken the teeth, and we have a higher chance of fracture of the acrylic teeth during the healing period of the provisionalization. And so we're always trying to aim to be slightly lingual to the tooth surface in the prosthesis. We're going to go ahead and layer PRF over everything in between the multi-unit abutments. We suture and we try to keep the flap as apically positioned as possible, and this is really a challenge in those types of cases. Traditional chairside conversion is done within the office, and the patient leaves with an immediately loaded prosthesis for the lower jaw. This is the post-op panoramic view. And again, we've incorporated angled implants in the posterior region to dodge the mental foramina and straight implants in the anterior region of the lower jaw. We go ahead and remove the prosthesis at about 3 months post-op in these types of cases. And again, we see the beauty of partial extraction therapy. Absolute maintenance of both width and thickness of keratinized gingiva surrounding our implants, which is absolutely necessary in these full arch fixed type of cases. We go ahead and restore our patients with a metal composite resin fixed hybrid in this case, and she was very pleased with the type of result here. So I really have three main conclusions to finish with today. Although I've been talking about preservation throughout this whole presentation, I do feel that it's very essential to still have the necessary skills and knowledge to perform augmentations. Whether we're talking about soft tissue or hard tissue, we have a lot of patients that walk through our door that have alveolar ridge deficiencies and soft tissue deficiencies, and we need to have the knowledge to manage those patients. And so with that said, we also need to recognize that tissue preservation will always outperform tissue augmentation. No matter how good we think we are at hard tissue augmentation or soft tissue augmentation, I don't think that we can ever outperform the natural tissue architecture that we are born with, and in this lies the importance of partial extraction therapy techniques. And last but not least, combining those partial extraction therapy techniques with immediate loading will be a huge asset. It will be a great service to our patients that they tend to appreciate a lot, and it's something that's also going to impact the success of our practice greatly. And so with that, again, I would like to thank Dr. Maurice Salama, Eddie Salama, and Tyler for this opportunity to share this presentation with my Dental XP family. And I look forward to seeing all of you again at the next Dental XP Symposium. Thank you for your kind attention.